Pleural effusion. Introduction. In a healthy human, the pleural space contains a small amount of fluid, about 10 to 20 milliliter. A pleural effusion is an excessive accumulation of fluid in the pleural space. Etiology. Accumulation of pleural fluid is not a specific disease, but a reflection of underlying pathology. The causes of pleural effusion vary widely, ranging from fairly harmless effusions, accompanying viral pleuritis, to prognostically highly relevant ones, due to congestive heart failure or cancer. There are two types of effusion: transudative pleural effusion and exudative pleural effusion. Common causes of transudates: congestive left heart failure, nephrotic syndrome, liver cirrhosis, and hypoalbuminemia. Common causes of exudates: pulmonary infections like pneumonia or tuberculosis. Malignancy: inflammatory disorders like pancreatitis, rheumatoid arthritis. Chylothorax due to lymphatic obstruction. Hemothorax. And benign asbestos pleural effusion. The Light criteria for differentiating a transudate from an exudate. A pleural effusion is an exudate if at least one of the following criteria is met. Protein concentration in effusion, divided by serum protein concentration, is more than 0.5. Pleural fluid lactate dehydrogenase is more than 2/3 of the upper limits of normal laboratory value for serum lactate dehydrogenase. Lactate dehydrogenase concentration in effusion, divided by serum lactate dehydrogenase concentration, is more than 0.6. History. History provides information about the possible etiology and guidelines for necessary investigations. A history of pneumonia suggests parapneumonic effusion. Fever indicates an infectious etiology. A history of cardiac, renal, or liver impairment can suggest transudative effusion. Older age, weight loss, and a history of smoking point towards a diagnosis of malignant pleural effusion. Recent leg swelling or deep vein thrombosis may result in an effusion related to pulmonary embolism. Trauma may result in hemothorax or chylothorax. Previous exposure to asbestos may be the cause of benign or malignant effusion related to mesothelioma. Recent esophageal procedures or history of alcohol binging suggest pleural effusion related to esophageal rupture. Signs and symptoms. A patient with pleural effusion can be asymptomatic or can present with exertional breathlessness. Patients with active pleural inflammation, called pleurisy, complain of sharp, severe, localized crescendo or decrescendo pain, with breathing or a cough. When the effusion develops, pain can subside, falsely implying an improvement in condition. Constant pain is also a hallmark of malignant diseases, like mesothelioma. Depending on the cause, the patient can also complain of a cough, fever, and systemic symptoms. Physical examination. Physical findings are signs of volume gain, reduced tactile vocal fremitus, dullness on percussion, shifting dullness, and diminished breath sounds. Physical findings such as ascites may indicate cirrhosis, ovarian cancer, or MEG syndrome. Unilateral leg swelling indicates pulmonary embolism, and bilateral leg swelling is associated with heart or liver failure. A pericardial friction rub occurs in pericarditis. Diagnosis. Chest radiographs are useful to confirm the presence of effusion. Ultrasound of the chest is more sensitive and useful for diagnosis of pleural effusion, and also helps in planning thoracentesis. CT scan is useful to determine the cause of a malignancy. Management. Once the etiology of pleural effusion is determined, management involves addressing the underlying cause. If patients do not respond to appropriate antibiotics and adequate drainage, then thoracoscopic decortication or debridement may be necessary. One should not remove more than 1,500 milliliters of fluid during a single attempt, as it can lead to re-expansion pulmonary edema. To get more such high-yield medical content, don't forget to subscribe. Basidia Med. The easiest and fastest way to take advanced clinical history.